Right now, someone nearby is having a stroke, and they have absolutely no idea. Within 4 hours, it will be too late to save their brain. That someone could be you, your spouse, the person sitting across from you at dinner tonight. Most people cannot name a single warning sign that appears in the hour before a major stroke hits. And that gap is precisely what makes stroke the #1 cause of permanent disability in adults. By the end of this video, you will know exactly what to watch for, what to do, and why the next 4 hours could be the most important window of your life. And I want to start by telling you something that most people, even most doctors outside of neurology, get completely wrong about strokes. I have watched patients arrive in my emergency department within the treatment window and walk out of the hospital. I have also watched patients arrive 1 hour too late, and the difference between those two outcomes is not equipment, not luck, not money. It is knowledge, just knowledge. Every 40 seconds, someone in the United States has a stroke. Nearly 800,000 people every single year, and 80% of those strokes are survivable with early action. What most people never realize is that the majority of strokes announce themselves hours before the major event, with signs so subtle that people dismiss them, lie down, and wait. Millions are dismissing those signs right now. That waiting is what costs people their brains. But if you know what to look for, you have a window. And inside that window, medicine can do something close to miraculous. So let's start with the first warning sign. And I want you to pay close attention, because I am going to ask you to do something physical in about 60 seconds. Imagine looking in the mirror and noticing that one side of your face has simply given up. Not a twitch, not a tremor. One entire side, slack, heavy, lower than it should be, like the muscles underneath have forgotten how to hold themselves up. That is facial drooping, and it is the most visible early sign of stroke. Here is what is happening inside the brain. Your motor cortex controls the opposite side of your face through a pathway called the corticospinal tract. A blockage in the left hemisphere droops the right side of your face. When the ischemic core, the area of actively dying brain tissue, disrupts that pathway, the signal to hold your facial muscles taut simply stops arriving. Think of it like a live electrical wire that has been cut. The switch is still on, but the lamp goes dark. I once treated a 52-year-old woman who told me she thought she had slept awkwardly. She dismissed the drooping for 2 hours. Her daughter noticed it at the breakfast table and called 911. That call saved her. Let's do a quick test together right now. Smile as wide as you possibly can, exaggerated, theatrical. Look at both corners of your mouth in a mirror or your phone camera. Are they level? Does one side feel like it simply is not cooperating? Now raise both eyebrows simultaneously. Does one side move less? This is the F in fast face, the most visually obvious signal that something is wrong upstream in the brain. If your smile is symmetric, breathe. A crooked resting smile you have carried for years is almost certainly not this. We are looking for new asymmetry, something that was simply not there yesterday. But the next sign, and I cannot stress this enough, is the one that gets missed most often, because it hides behind a belief that almost everyone holds, and that is completely wrong. Most people assume strokes are painless, that you simply go numb, or weak, or confused, and that a headache means something far less serious, like a migraine or tension. And honestly, that assumption makes complete sense. But here is what we actually see in the clinic. A hemorrhagic stroke, where a blood vessel ruptures rather than becomes blocked, announces itself with what neurologists call a thunderclap headache. Not a dull ache, not throbbing pressure. A sudden, explosive onset of pain that patients consistently describe as feeling like someone hit them in the back of the head with a baseball bat. Maximum intensity in under 60 seconds. What seems like just a headache is actually intracranial pressure spiking as blood floods spaces it was never meant to occupy. This is called a subarachnoid hemorrhage, bleeding into the fluid surrounding the brain, and it irritates the meninges in a way that produces a pain unlike anything else in neurology. Imagine squeezing a water balloon inside a sealed glass jar. The pressure has nowhere to go. I once saw a 47-year-old marathon runner, fit, no history, no warning, describe his headache arriving like a thunderclap mid-run. He drove himself to urgent care. He was in neurosurgery within 2 hours. This is what neurologists know that most people, and even many general practitioners, do not always communicate clearly. Any sudden, maximum intensity headache with no prior history of identical episodes is a 911 call, not a call to your pharmacy. And here is where it becomes truly fascinating, because the next two signs are physically connected to each other inside your nervous system in a way that reveals exactly how a stroke systematically dismantles the brain from the inside out. These two signs almost always travel together, and when they do, they are telling you that the same blood vessel supplying both the language centers and the motor cortex has been compromised. Sign 3 is sudden arm weakness or numbness. The middle cerebral artery, the brain's largest and most frequently blocked vessel supplies both the motor strip controlling your arm and the sensory cortex registering touch and position. When it is compromised, the neurons in the ischemic penumbra, the at-risk zone surrounding the dying core, begin silencing within minutes. Think of the penumbra like the edge of a wildfire. The trees have not burned yet, but they will if nothing stops the fire. That is precisely what TPA, the clot-dissolving medication, is designed to do. It is the fire break. Here is a test. Stretch both arms straight out in front of you, palms facing upward, and close your eyes. Hold that position for 10 full seconds. Does one arm drift downward without you intending it to? Even a subtle drift matters. Sign 4 travels alongside it. Sudden speech difficulty. There are two distinct forms. Aphasia, where the language itself breaks down. The patient knows what they want to say, but cannot retrieve the words or cannot understand what is being said to them. And dysarthria, where the words are present, but the mouth cannot produce them correctly. Slurred, thick, imprecise. Broca's area handles expressive language. Wernicke's area handles comprehension. Both live in the dominant hemisphere, typically the left, fed by that same middle cerebral artery. Aphasia is like a library where all the books exist, but someone has removed every shelf sign. The patient knows the information is there, they simply cannot retrieve or deliver it. I once had a 61-year-old retired teacher, sharp, articulate, someone who had spent decades choosing words with precision, call her daughter during a stroke and produce only a single repeated syllable for 4 minutes. Her daughter called 911 immediately. Her mother received TPA within the window. She regained 90% of her language. The patient with these combined signs often appears calm, even cooperative, but what looks like confusion is the brain's language center going offline in real time. Now, I want to share 2 more signs with you, and one involves a patient story that I still think about today because it shows exactly what happens when these signs are mistaken for something harmless. I want to tell you about a patient I will never forget. He was 58 years old, a high school football coach, physically active, no significant medical history. He came in, not by ambulance, he walked in because he thought he had an inner ear problem. He had been dizzy since that morning. He had bumped into a door frame twice getting ready. His wife thought he had vertigo. He thought he had vertigo. He had a cerebellar stroke. By the time he arrived, we were 30 minutes outside the treatment window. He survived, but he spent 4 months in rehabilitation, learning to walk in a straight line again. He told me later, "I kept thinking it would pass." Those words stay with me. Sign 5 is sudden vision change. This includes sudden loss of vision in one eye called amaurosis fugax, a classic TIA warning double vision, or loss of an entire visual field. Patients describe vision loss as a curtain or shade being drawn across one eye. The posterior cerebral artery supplies the occipital cortex, your brain's visual processing center. Try this. Cover each eye alternately right now. Is each eye individually clear? Any sudden difference you have not noticed before is worth taking seriously. Any new, unexplained vision change is neurological until proven otherwise. Sign 6 is the one that cost my patient 4 months of rehabilitation. Sudden loss of balance or coordination, called ataxia. The cerebellum is the brain's autopilot. It coordinates balance, fine movement, and spatial orientation. When it loses blood supply, the autopilot shuts off mid-flight. Posterior circulation strokes affecting the vertebro-basilar system are the most commonly missed strokes in emergency medicine precisely because the symptoms so closely resemble benign vertigo. Not every dizzy episode is a stroke. Positional vertigo, inner ear infections, and dehydration all cause dizziness. But sudden, severe, new dizziness combined with any other sign on this list changes everything. Now I want to share something that goes well beyond the standard stroke warning list, a connection between stroke and a system most people would never associate with the brain, and it completely changes how we should be thinking about prevention. This next piece of information is something that even many people who know about stroke, who have read extensively, who have had a family member affected, have never fully understood, and it may honestly be the most important part of this entire video. Approximately 1 in every 3. Ischemic strokes, the kind caused by a clot blocking a cerebral artery, is not caused by anything happening in the brain at all. It originates in the heart, specifically in an irregular rhythm called atrial fibrillation AFib, where the upper chambers of the heart quiver chaotically instead of contracting with coordinated force. When the atria fibrillate, blood pools rather than being ejected cleanly. Pooled blood clots. Those clots then eject into the bloodstream and travel directly into the cerebral arteries, where they lodge and cut off oxygen to downstream neurons within seconds. Imagine a water pump that has stopped pulsing rhythmically and is simply vibrating. The water becomes turbulent, debris collects, and suddenly that debris fires through the pipe at full pressure. What makes this genuinely alarming is that AFib is frequently completely silent. No palpitations, no chest pain, no awareness whatsoever. Many stroke patients discover they had AFib only after the stroke has already occurred. Most people assume stroke prevention means managing blood pressure. It doesn't stop there. The heart and the brain are in constant conversation, and when the heart loses its rhythm, the brain ultimately pays the price. Checking your pulse regularly for irregular rhythm and using a smartwatch with AFib detection capability may genuinely be among the most life-saving decisions an adult can make today. So now that you know what to look for and why it happens, let me be very clear about exactly when you should act. And more importantly, let me make sure you leave this video feeling ready, not afraid. Before you spiral into health anxiety, and I say this as someone who has seen what health anxiety genuinely does to people, I want to give you the specific thresholds that actually matter clinically. One isolated sign with an obvious explanation: you slept poorly, you are dehydrated, you have a documented migraine history that alone may not be a stroke. But two or more of these signs appearing suddenly and simultaneously, particularly facial drooping combined with arm weakness or speech difficulty, that is a 911 call right now. Not your family doctor. Not a wait and see. 911. A single numb hand is often carpal tunnel. A dizzy spell after standing quickly is almost always a blood pressure drop. An isolated headache without thunderclap onset is very rarely hemorrhagic stroke. It is not weakness to call 911 when you are unsure. In emergency medicine, we would always rather evaluate 10 people without a stroke than miss one person who has one. And if you have had any episode, even one that fully resolved in minutes, that resembles what I described today, please speak to your doctor this week and ask specifically about a TIA, a transient ischemic attack, because a TIA is the brain's warning shot before a major stroke arrives. And knowing when to act is only half of what I want you to take away today, because there are concrete things you can do starting right now to dramatically reduce your risk. You now have knowledge that most people simply do not have. And knowledge without action is just anxiety wearing a medical disguise. So here is what action looks like. First, learn fast and teach it today. Face drooping, arm weakness, speech difficulty, time to call 911. That acronym takes 30 seconds to teach someone you love and could genuinely be the most important 30 seconds of your relationship with them. Teach it at dinner tonight. Second, know your numbers and your rhythm. High blood pressure remains the single most modifiable stroke risk factor. Check it regularly. Home monitors are inexpensive and accurate. If you own a smartwatch with AFib detection, actually use that feature. And if you have noticed irregular heartbeat episodes, tell your doctor explicitly and ask about a Holter monitor, a continuous heart rhythm recorder. Third, the lifestyle foundation is not optional. Regular aerobic exercise, a Mediterranean-style diet rich in leafy greens and omega-3 fatty acids with reduced sodium, combined with not smoking, reduces stroke risk by up to 80%, not marginally, 80%. Remember the AFib connection. Reducing alcohol consumption directly lowers AFib risk and is therefore a direct stroke prevention strategy. And if your doctor has already recommended blood thinners and you have been hesitant, please revisit that conversation. Newer anticoagulants have genuinely changed the risk calculus, and that discussion is worth having again. You have done the hard work of learning this today, and there is one more video I think you should watch before you close this app. If what I shared about atrial fibrillation surprised you, and I strongly suspect it did, then please watch my video on the silent signs of heart disease that most people mistake for normal aging. The heart and the brain are either protecting each other or failing each other every single day, and that video will complete the picture I started building here. I made it specifically for people who watched this one, people serious about their health, who want the full clinical picture, not just the headline version. As always, I am genuinely glad you are here. The fact that you stayed until the end tells me something real about you. You care deeply about the people in your life. That matters more than you know. Take good care of yourself. I will see you in the next one.